the APSF. This meeting led to the inception of the APSF. And over 4 decades, there's been so much progress related to patient safety, and APSF has really helped transform anesthesia care and really helped transform the care for our patients. I'd like to begin by really describing a little bit about how it all started. And it was almost 40 years till this day, about a month away, in Boston, where doctors Jeff Cooper, Rick Fitz, and Jeep Ellison Pierce congregated an international group with the support of Harvard Medical School. And from that meeting, the following year, the APSF was formed. Later today, you're all in for a treat, as the one and only Mark Warner will serve as a moderator, interviewing some of the pioneers that were at that very conference. But today and tomorrow, we're going to delve into 2 really challenging topics. That is medication safety and opioid safety. And as we know, with regard to medical errors, medication errors are the most common type of medical errors. These errors actually claim the lives of thousands of Americans annually and injure millions. The cost of medication errors amounts to over 40 billion with a B, in the US annually. And there's several different issues in the perioperative environment that contribute to medication errors. You know, one is the acute setting where we deliver medications. Some of the checks aren't present just based on the systems issues. The pressure that we see with the workforce shortages that we have, and production pressures that those that practice clinically see frequently, the lack of standardization, communication errors and failures, and then when an error occurs, these really can contribute to significant patient harm. And so today, not only are we going to discuss the issues, but we're going to talk about actionable solutions in terms of creating a safer environment to care for our patients. And another area we're going to focus on is harm related to opioids. And unfortunately, I think now the public it has become such an issue in terms of mortality that the public is aware and, you know, and impacted by deaths related to opioid consumption. Last year alone, over 80,000 deaths, which is actually a slight decrease from the year before. So there has been some progress made in the area. Interestingly, for many patients, their first exposure to an opioid is in the perioperative setting. And then in terms of costs related to healthcare events related to opioids, we're at $35 billion. But there are some promising strides made. The FDA last year actually approved naloxone as an over-the-counter product, and that's something to be celebrated. Again, some of the factors related to opioid harm are similar, right? Lack of standardization, issues with communication and such. And so our goal over this day and a half is to gather our groups and really work on ways to help enhance monitoring, education, and such related to opioid harm. The APSF newsletter is one of the most read pieces of literature regarding anesthetic care in the world, with a circulation of over 700,000. This newsletter is translated into 8 languages. And these are some of the articles, some of the content related to medication safety and opioid harm over the last few years. In addition, the APSF has had 4 different conferences related to these 2 broad topics, 3 related to medication safety and 1 related to opioid harm. And from these conferences, there's recommendations that have been developed And over time, we've seen the impact of having these recommendations adopted, but change occurs slowly. I wanted to share this slide here that looks at some of the two APSF conferences and then ISMP, which we'll hear from later on today from Dr. Rita Chu, about the recommendations that were made and some of the progress that's made and some of the overlap. And so if you look at this slide here, the yellow are the recommendations that were made in 2010, 2018, and then 2022. And we'll be discussing several of those today in different ways. Some of them will be via poll everywhere, and some of them will be, with our esteemed panelists. And then lastly, in our breakout session towards the end of the conference. In 2022, APSF formed 10 patient safety advisory groups, and one of these groups was dedicated to medication safety. And the group was multi-stakeholder with international presence. And these were the recommendations that were made. And these were recommendations made from previous conference recommendations from multiple sources and also from the literature. And these included the use of pre-filled syringes, which in 2010 was kind of a novel concept. And now when I speak in groups and I ask hands to be raised, it's pleasant to see more hands raised and more adoption with pre-filled syringes. The second is point of care scanning. The third is working with regulatory bodies. And I'm so happy to see in this room today, we have FDA, we have standardized setting organizations, USP, we have the APSF, ISMP, WFSA represented. We have manufacturers represented here. We have vial top makers represented here. We're finding ways to avoid items like look-alike vials that continue to contribute to medication errors. Another recommendation was the use of standardizing concentrations, because the USP had a article, it's a few years old now, from 2008, where pharmacy directors were interviewed, and for certain medications, such as phenylephrine, there were 45 different concentrations reported. That's startling. So it's no surprise that medication errors continued to occur. And then lastly, utilizing the talent in the room here and being able to develop online resources, not only for those of us that reside in the US, but also international as well. So let's get started. I want to mention that this conference actually filled. We are at max capacity in person. And I want to also recognize those that are joining us virtually. We have over 200 virtual participants at this meeting. And we're going to start with a quick poll. And I'm going to ask you all, both those joining virtually and those in person, to take a few seconds, click on the QR code, and then click on where you're traveling from. I'll give everyone just a few seconds to do that. This is going to be an engaging next day and a half. Several of our speakers will be polling the group both virtually and in person. And so let's see what the results show. And it's actually fun to see it all pop up. And I'm going to thank Dr. Arnie for all of his skill and expertise in managing so much of this, especially the poll everywhere. So as you can see, we're pretty well represented, both within the US and beyond. And we'll be using poll everywhere throughout the talks as well. So you were all actually sent a pre-conference survey, and I wanted to just share some of the results regarding the pre-conference survey, just a few questions. And one was how frequently those of you that practice clinically observe drug administration errors, and the majority was at least monthly observations. That's something that I thought was significant. And then the most common medication errors are consistent with the poll audience, as with the literature, which are substitution errors and dosing errors. And then in terms of strategies to standardize, what type of strategies are there? And those include pre-filled syringes, having standardized practices for ready-to-use bags, considering standardizing both the vials, caps and vials, and then also using technology in terms to help improve medication safety. With regard to opioid harm, almost 30% thought that there should be more priority given to assessing patients preoperatively in terms of opioid administration, and then creating standards for acute pain management as well throughout. And so as we gather here today, we look back on 40 years, we've made tremendous progress. The future looks bright, both in terms of, having this group here present with, education, determination, and really moving forward in terms of patient safety. The conference, over the next day and a half, you'll hear from, experts in the field, from multiple practice backgrounds and such. And then what we will be doing at the end, we'll be breaking out into 5 different groups, self-selected. You'll choose which group you identify with to help contribute to that. And then we'll gather at the last hour of the conference and go over some of the preliminary recommendations. When I think back, so much has changed in 40 years. And some things have not. And I wanted to share this slide, picture that was shared by Dr. Jeffrey Cooper. And it's Dr. Richard Kitts, 40 years ago here in Boston at a breakout session. And some things don't change, and that is conversation and flip charts. So we'll be using flip charts tomorrow as well when we do our breakout sessions. And now, without further ado, it is my pleasure to invite Dr. Dan Cole, who is the president of APSF, to the stage. Thank you. Okay. Great.
Well, thank you so much, Elizabeth, and good morning to everybody, and welcome to our conference. This was brilliantly planned. I'll give a shout out to our planning committee here in just a minute. But to go on, a thank you to our committee. Elizabeth has planned and led a fantastic group. I would call out Nat Sims on the right there. I think about a year and a half ago, I was here at MGH giving a lecture, and he actually came up with this idea. And I said, well, what better way to have this conference than to celebrate it here, where it all started. And I can't talk about APSF, and I see her way in the back out in the hall, Stacy Maxwell. She is the glue that holds APSF together and put in a phenomenal amount of hours over particularly the last few weeks. So thank you to our planning committee. As Elizabeth said, this kind of all started 40 years ago. And you can see a picture here, and I don't know if you can pick him out, but Jeff Cooper is sitting at this front table, and he is somewhere in there. I'll give you a hint. I think he had facial hair in the picture. But actually, one of the icons and really a pioneer in patient safety within anesthesiology. A picture of our board as of 2 days ago. It's changed a little bit, but you can see it looks a little bit different and has kind of built upon the legacy that people like Dr. Cooper and others have built. We're a unique organization in that we're very collaborative. We work with all stakeholders in the perioperative space. And particularly, we're one of the few organizations that works closely with industry. We embrace that cooperation, that collegiality. As I've said many times, and we were at the Ether Dome yesterday, without industry, I would still be given ether as an anesthetic. So again, we embrace industry, we understand the conflicts of interest, we manage them to try and make synergies of interest. Our levers of action here that by and large that we employ are research. We support research grants every year, education such as this Stoelting conference and other educational activities, online educational activities in conjunction with the American Society of Anesthesiologists. We are a foundation of the American Society of Anesthesiologists and have a great working relationship with them. The newsletter Elizabeth already talked about. The big thing there is that the newsletter is free. So if you want to get it, just go to the website, sign up to receive it. It comes out every year. And it is more than just the newsletter. I've always thought it should be a peer-reviewed publication. The articles, the quality of the articles are superb. I said earlier that we collaborate with basically all organizations in the perioperative safety space. Communication platforms, we have a presence in social media, over 1,000 or no, over 1 million hits on our website every year. And then advocacy, we're not an advocacy organization. The responsibility for that falls primarily on me, but we do dabble in it from time to time on very important issues and support advancing the cause in the halls of where decisions are made. These are our priorities. We have 10 priorities that we align all our activities around. The top 3 tended to overlap, and so we've kind of coordinated them into one common type of a group that is working together. I would say that there are 2 others that should be on here, including healthcare equity and technology, but we decided that those don't really belong as kind of a silo as people see these 10 priorities, but they should be weaved into every one of those 10 priorities. Next year, I'm very happy to say that we already have a conference plan in the planning stage. We'll be in Chicago the same time, and May Pian Smith back there, she's right here at MGH, and she is the past president of the society, the immediate past president for the Society of Obstetrics and Anesthesia and Perinatology. And there's going to be a heavy lift with Megan Fall Lane. I don't know if she's here yet, but she is around. So if you see her, she has a role with maternal equity and outcomes at Penn. So feel free to provide input to any one of those. I think it's an important topic. It is too many wrong things happen in obstetrical care in the United States and throughout the world. And we hope to kind of make a dent in what we can do. And again, I talked about industry earlier, and I really want to give a thank you to, how do I go back? I want to give a thank you to our industry supporters for this conference, Fresenius Kabi, ICU Medical, IntelliGuard, Medtronics, and Vertex, who again help support and make all this happen. Everything is free that we put out through APSF, and they helped make it free to people. And we're an organization that depends on donations. We have no large endowments. This thing is really sensitive. And so if you feel so moved, there's a dip jar out there. If you want to make a contribution to APSF, we use that those funds wisely. If you feel so inclined to sign up for $250 each year on a recurring donation, we'll send you one of these APSF vests. For those of you that work in cold operating rooms, we'll keep you warm. Speaking of cold operating rooms and warmth, I want to give 3 shout outs now, or acknowledgements. We have revised our fire video, our surgical fires video, and we have an actual web page that has surgical fire resources. It has our longer video, which is used a lot in hospitals for credentialing. And then we have a shorter one that is now 6 minutes long. and it is in the process of being translated into, I believe 9 different languages. A shout out to George Shapiro back there who helped guide this mission. And then Rafael Ortega, who was going to be here but had something last minute come up here in the Boston area, has put together the video, put a lot of hours, volunteer hours in, and is in the process of translating it again into 9 different languages to be disseminated across the world. So this has been very, very popular. It has gotten a lot of traffic on our website, and amazingly, people still actually are viewing the 18-minute video more than our 6-minute video. But we did think that everyone communicates now with 140 characters, so we need to distill it down to something that people could at least be interested in to read. And I don't know if Julian Goldman, do you want to stand up here? If you want to go talk to him about his effort, it's phenomenal. He's worked with APSF on this, but it's SAMS, the Smart and Autonomous Medical Systems, and it's basically as transformative patient care solutions and adopting them safely and efficiently. There's a QR code there that you can scan if you're interested in learning about it, or see Julian at the breaks. And here is the first project that he's working on. Again, QR codes. He held a symposium last June, and then a participation form if you're interested in engaging. But the first project is closed loop control of intravenous anesthesia, which is, again, one of these emerging technologies that should make anesthesia safer. And we thank Julian for all of his work. And then finally, we have a training quality initiative that we are going to announce and give out at this annual meeting. And I will not talk too much about it or the recipient, but give the podium over to Brian Cammarata.
Hello, everyone. And I join Dr. Cole and everyone in welcoming all of you to the APSF conference. My name is Brian Cammarata, and I have the honor of chairing the APSF Trainee Quality Improvement, or TQI, subcommittee. In 2015, APSF introduced the annual Trainee Quality Improvement Program. The program has tracks for anesthesiology residents, student CRNAs, and student AAs, and is designed to identify the best anesthesia-related safety work on a national basis. Following a brief COVID hiatus, the APSF Leadership and TQI Subcommittee reintroduced the program in 2024 and received a great response. The 2024 winning submission was authored by Dr. Akash Patel and his associates. Dr. Patel is in the audience, and I'll have him stand in just a moment. His project is entitled Language No Barrier, Innovating Translation Services for Perioperative Care Excellence. By way of background, Dr. Patel is a New Jersey native who started his medical career in an accelerated 7-year MD MBA program. He then completed his anesthesiology training at Cooper University Hospital, where he currently serves as an assistant professor in the Department of Anesthesiology. Dr. Patel's winning submission will be available in paper form for those of you who still like paper following this morning's break. Additionally, in about 2 minutes, will be available at the APSF website in a downloadable form. Additionally, Akash is attending the Stoelting Conference. He will be available to discuss his project and really important ongoing work in the language translation safety space. So on behalf of Dr. Cole and the APSF TQI subcommittee, we are honored to present the 2024 APSF TQI Award to Dr. Akash Patel. We're really proud of his commitment to patient safety. Now, one more part. People may ask, well, what about 2025? What are all of you doing? So yes, indeed, there will be a 2025 program we're preparing right now. We encourage every training program to participate. Again, anesthesiology residencies, CRNA programs, NAA programs. We want everyone's input. Please check the APSF website in early January, where we will have program and submission details. Thank you, and I will return the podium back to Dr. Cole.
And with that, Nat Sims will come up and start the next session.
Thanks. Good morning, everybody. My name is Nat Sims, and my middle name is Stopwatch. My goal is to get you to the break at 9:10. We have 4 terrific talks. I'm not even going to introduce everybody because I want us to get to the meat of the presentation. If you can come back and put the first talk up, that would be great. Sevan, will you come up if you're, get our whole panel up actually, and take these chairs. And my goal again is to limit each talk to 12 minutes so that we switch over on time and have time for, I think, all the questions. Elizabeth, the intent is to have all the questions occur at the end and no questions at the end of each presentation. So,
Matt, can you use the microphone?
sorry, yeah. So, great, and you can do your own introduction and we'll get started.
Sure.
And
Yep. Yes.
perfect, yeah. And I will have a stopwatch running and I'll kind of make noises.
Thank you.
at
Okay,
10
great,
minutes or
sounds
so.
good. And this is good morning, everyone, and thank you for the opportunity to be here today. My name is Sevan Kolejian, and I'm a director at the FDA Division of Medication Assessment and Medication Error Surveillance. I would like to start with a disclaimer that the presentations reflects today is my own views and should not be construed to represent FDA's views or policies. With that, I'd like to start a little bit about what we do at FDA in terms of medication error prevention. When we think about the product life cycle, FDA in post-market setting receives medication error reports. We review the medication error reports. We have a team of multidisciplinary medication safety analysts who conducts the risk assessment from the reports received in the post-market, and in the pre-market setting, we have a team of analysts who reviews the reports, who reviews the medication error perspective, the product labeling, container labels. I'm referring in terms of, and I speak a little bit later on in my presentation about it, as well as instruction for use for the product and the prescribing information. So let's talk a little bit about what we do in a pre-market. So obviously in a pre-market setting, we consider the reports and the lesson learned from the post-market reports. And based on that, we kind of consider the entire medication use process when the product will be marketed. We think in terms of who will be the end user for that product will be. We think whether it's a patient who will be preparing the product, self-administering it, or I guess relevant to your case would be potentially anesthesiologist preparing at the procedure site and administering it. We also think about the various environment of use, and the environment of use could be at home or could be in a healthcare setting, could be at a pharmacy or the physician office. And primarily, we think about how that product will be used in terms of the user, how they will be interacting with it, how complex is the preparation, how complex is the information needed for safely to prepare and administer the product. So medication error can happen in any stage of the medication use process. And obviously, we can't predict all possible medication errors in a pre-market setting. However, by conducting the risk assessment on the product and understanding the end user perspective, that helps us to prevent prevent the medication error in the post-market setting. We primarily review product labeling. We ensure that all the product relevant critical information is presented on the user interface. And by user interface, we are referring to all the components that the user will interact. This is an example of a container label. As you can see on this example, there is a primary display panel, which is the middle panel of a container label, could be a vial. And the user will rely on the critical information present on the display panel to make a decision whether it's correct product, what's the strength of the product, and how potentially will administer. When we review, we ensure that the proprietary information, established name, strength of the product, as well as cautionary statements are present if needed. You can also notice there's a side panels, and the side panels might have additional information, such as potentially recommended dosage or other relevant storage information. But our focus is to ensure that end user, when they're interacting with the product, container label and carton labeling, as well as prescribing information and the instruction for use, they're able to locate all the information needed for them to prepare the product, prescribe the product, as well as safely administer the product. So we receive over 100,000 medication error reports in post-market. Even though this is a voluntary reporting system, and we know that there's much more occurring in the marketplace. Nevertheless, as I mentioned before, those post-market reports are very valuable for us because they actually inform the work we do in the pre-market review space. We encourage that all healthcare providers, as well as patients and consumers, to continue reporting medication errors, and not just medication errors, any circumstances that potentially may lead to medication errors. And by circumstances, I'm referring to, for example, lookalike label and labeling. Not necessary the error happened, but if you observation is that potentially may lead to medication errors, we encourage you to consider submitting to FDA. We do realize that we receive a small subset of medication errors. What's happening is more. Nevertheless, every report, it provides a very important, valuable information for us. I'd like to share an example of a medication error report. We don't receive many from anesthesiologists, but this is a very good example of a report that anesthesiologists reporting that a patient experienced seizures and cardiac arrhythmias after a patient received a tranexamic acid instead of intended bupivacaine for spinal anesthesia. And the report also says that this is a very serious national health emergency, and every hospital and healthcare provider needs to be urgently alerted, and that the FDA should take immediate action. So our analysts, when they receive this report, they will review and assess the report. They will think in terms of what type of error it is, or where potentially this happened. Was there any recommendation from the reporters? What was the contributing factors? And what type of a regulatory action FDA might take? And the type of regulatory action can be various. Could be in terms of making revisions to the label and labeling, or providing a safety type of a communication to healthcare providers, as well as in certain instances, we might consider revising the design elements of the product, could be the packaging or the way its user interacts with it. In terms of considerations when we are evaluating this type of errors, we specifically kind of trying to understand if that these errors happen, is there's any additional reports that inform us. Most of the reports we receive doesn't have all the information is needed, unfortunately. When we look at it, sometimes the reporter says this might be a potential for error, but it does not provide any additional information. For us, a good report is that has all the information needed for us to analyze. And it doesn't have to be multiple reports, it could be one good report. And the example previously that I provided, in this case, after evaluation by the analyst, FDA made a decision to issue a safety alert, which alerts all the healthcare professional about the risk of the medication error with the tranexamic acid injections. Preventing medication error is a shared responsibility. It's not just on one organization, on one institution or individual. In our minds is we want to encourage and facilitate medication error reporting. We would like to establish and foster partnerships to share medication error information and support research to advance the science of medication error prevention and analysis, and including the causes of the errors and effectiveness of the mitigation strategies. We consider using novel approaches when we're reviewing it and other approaches that potentially can minimize medication errors. Our intent is prior to medication goes on the market to do what we can to prevent the error from happening. However, those reports that we receive in the post-market space informs about our review. That's why it's very critical to receive those reports. So just a couple of key takeaways. As I stated, preventing medication errors requires collaboration and shared responsibility. We encourage reporting of medication errors, including circumstances that may cause or lead to medication errors. It doesn't have to happen, an error. It's important to prevent it when you observe first potential error from happening. And regulatory actions that FDA might take may include revisions to the product container label, carton labeling, instruction for use, prescribing information, and as well as safety communication, and requesting a product design updates that may include the repackaging or other aspects of the product. The information we learn from the post-market surveillance informs our pre-market review process, and we aim to reduce the likelihood of medication errors occurring with a medical product prior it hits to the market. And with that.
Terrific. Thank you so much.
Sure.
So as I said, time is of the essence. We're going to hold questions until 8:55 to 9:10 for all four talks, but we're ahead enough that if somebody's got an incredibly compelling story that they want to tell in 1 minute or less, I would grant them the floor. And there are microphones if anybody has one key question, or if not, we'll proceed with the next talk. And I've got to pull up, or maybe you can come up and switch the slides. Rita, we're so honored to have you here.
Thank you. Which one's yours? This one? Nope. Yep. No, 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 it's not up. Oh.
No, that's Patricia.
Oh, honey, I'm sorry. I don't see yours. Okay. Can we go to Patty and then we'll figure out?
Yes.
Which is one?
Do you want to switch the order?
Yeah.
And have Patricia from the IHI.
I'll figure it
It's a
out.
wonderful presentation, and we'll maybe do some emailing to get the.
Okay, we're not in safety if we don't know how to adapt in real time. Good morning, I'm Patricia McGaffigan. I work at the Institute for Healthcare Improvement, and I am the substitute for Dr. Jerry Hickson, who was unable to be with us today. He sends his regrets, and I'm going to talk to you a little bit about what IHI is doing in the world of safety that is not necessarily specific to medication safety or opioid safety, but is clearly relevant to safety. So with that, let's kick in a little bit and get started. We're at 40 years of the Anesthesia Patient Safety Foundation. As we come into the fall this year, we are also at 33 years, I think, for the founding of the Institute for Healthcare Improvement by Dr. Don Berwick. And we are 25 years into the publication of To Err Is Human and the aftermath of the impact of that report, which many of us are very familiar with and talk about quite frequently. And one of the most important aspects of this report was identifying the fact that humans are fallible. And yet, at the same time, and amid all of the recommendations of To Err Is Human, I think it's fair to ask ourselves, is the progress that we've made transformational, adequately transformational and sustainable in safety? And over many years between the National Patient Safety Foundation, where I worked before the merger with the Institute for Healthcare Improvement, we've pulled together expert panels to examine what's getting in the way of the transformational progress that we know that we need to achieve, despite many pockets of excellence and, quite frankly, the leadership in the anesthesia community of the Anesthesia Patient Safety Foundation. So what we're really seeing, and the short story here is related to a quote from W. Edwards Deming that talks about how a bad system will get in the way of a good person every time. And what I'm going to talk to you today is what we're doing in IHI to help move the shift in the direction to be able to think about how we improve systems that have the impact that supports our advancement in safety across the many challenges that we've been dealing with. And I'm not going to go into detail on this slide, but these are some of the examples of the shift that we're really focusing in on in our work at IHI, from thinking about safety as something that we have because we have a grade on our website, to recognizing that safety is an emergent property of the system, a real-time reality of the system. And while what we've done in the past can serve as an indicator for where we might be in the future, it is not necessarily any guarantee, as you know, because it's what we're doing in each and every moment of our work that determines whether and how we're safe. We spend a lot of time measuring and reacting to errors after harm occurs and really trying to focus on fixing people in the process, with a far less proportionate investment in the intentional design of systems that proactively identify and mitigate risk, and co-engineering those systems with the expertise that we once had a lot of in the aftermath of the publication of To Err Is Human, with human factors experts and safety scientists and systems engineers who helped us create worlds that were safer. We spent a lot of time trying to constrain human variation, which is necessary when we think about the importance of standardization in our work, and we've already spoken about that today. Yet we've got a high degree of whole system variation in how organizations are structured and how they're supportive of safety, and how they're intentionally designed, and how they use humans as assets versus liability, and how they ensure that safety is the responsibility of all and that everyone is held accountable for it. Similarly, we've had a lot of focus on physical harm for patients and families, very much appropriately so. And at the same time as we looked at our evolving definitions of harm, we're looking at physical harm, non-physical psychological harms, inequities as harms, and also recognizing something that APS is very much focused in on, which is the safety and the well-being of the healthcare workforce. We've also talked about, high reliability organizations, which everywhere we go, everywhere I go in my travels, folks say we're a high reliability organization. And we ask for, how is that so? So we've trained everybody on high reliability and the 5 principles, yet high reliability organizations as a noun is probably more of myth than recognizing that high reliability organizing is the day-to-day work of organizations. And finally, we're spending a lot of important time measuring and reporting on culture and not necessarily ensuring that we are continuously improving the cultures in which we operate, and recognizing signals and cues, such as whether or not reporting rates have changed, and recognizing that decreases in reporting may not be the signal that we're looking for. Looking at variation and workarounds, and instead of recognizing those as important cues that something in the system may not be working well, we tend to point our fingers at the individuals and say there's something wrong with them without taking an equal look at the system itself. So let me talk about how this is coming alive in 3 areas at the IHI. The first is through the National Action Plan, the Safer Together National Action Plan. The second is through some work that we've done and partnered with some of our federal agencies on, that is introducing some new measures that are coming very soon to an acute care hospital near you. And I'm going to talk for a moment about certification. The Safer Together National Action Plan was something that was envisioned by our board of directors, of which, by the way, Dr. Hickson is chair. And it was the first time that in this country, we had really convened a large number of organizations to come together and collaborate on a national action plan for safety. In fact, at the outset, there were 27 organizations. There are many more now. They include groups like ISMP and the FDA, 6 federal agencies in total, American Hospital Association, the American Nurses Association, the Joint Accreditation, and I'd be remiss if I didn't emphasize the important contributions that our patient and family partners have made in this work. Instead of focusing on any specific challenge in patient safety, we focused on what was challenging about the ecosystem that we could work on, and the 4 areas of the National Action Plan that are foundational to this work are areas that we have referenced, I think, in several cases so far today, and we'll be talking about through the duration of this conference: culture, leadership, and governance, meaningful patient and family engagement, workforce safety and well-being, and the learning system. And across these areas, we embedded several principles, 3 of which are on the slides here today. They include ensuring that our work would be very much person-centered on patients and families and the workforce. Secondly, that what we developed would be relevant in all care settings across the continuum. And third, the inextricable relationship between patient safety and equity, with the recognition that inequities are harms. There are 3 components to the National Action Plan, and many of the organizations in this country and outside of the country, quite frankly, are using the National Action Plan to be able to identify opportunities for improvement in the foundational areas that we talked about, and again, that are inextricably linked to whether and how safety challenges such as medication errors come into play. There's the National Action Plan itself. There's an online self-assessment that organizations are using. Actually, I think hundreds of organizations right now are pulling together core teams with an executive sponsor and various representatives from across the organization to really get a handle on the current state. And one of the most important, I think, stimulus that this has provided are conversations that are not necessarily happening in organizations, where a CEO, for example, might think that all is well and good when it comes to patient and family engagement, and others in the group are saying, hey, we're not necessarily legends that you think we might be. We've got great opportunities for improvement. And then there's an implementation resource guide, and all of these are freely available on the IHA website. This is an example of culture, leadership, and governance from the organizational assessment tool. I just want to point out what I referenced just a moment ago. In the left-hand side, 2 of the 7 categories for culture, leadership, and governance include job descriptions and annual reviews. And as you move from left to right and you advance to higher levels of scores, organizations are assessing whether or not the job descriptions of all senior leaders, applicable to all senior leaders as well as trustees, are integrating safety into the job descriptions and whether or not in those annual reviews that is being taken into consideration. There's a lot of fine print on here, but again, I just wanted to call that out because organizations will say, we've never had this conversation in the history of our organization. Second area, how many of you are familiar with the new structural measures that are headed our way? Okay, this is probably something we could spend a lot of time on. If you were working in an acute care hospital that is subject to the CMS inpatient prospective payment system and or the 11 cancer hospitals, effective this year, there are 2 new structural measures that are coming into place that are about patient safety and about age-friendly care. And I know that both of these considerations are highly relevant for the anesthesia community. They're largely informed by the efforts that we and our partners have had in creating the National Action Plan and the age-friendly framework. And the short story is that in the applicable hospitals for this year, starting in January, calendar year 2025, hospitals are obligated to report on how they're performing across both of these measures. In 2026, the scores will be publicly reported on the Care Compare website. And in fiscal year 27, hospitals that fail to report will be subject to financial penalties. So my appreciation is similar to what I just saw when I asked how many were familiar with this. These are measures that folks are generally not familiar with, but again, are coming very, very soon. The patient safety structural measure has 5 domains that are really reflecting whether and how organizations have implemented some of the evidence-based and more salient processes associated with culture and leadership in organizations. These are, again, foundational processes and activities that are very much aligned with the National Action Plan's foundational areas. And the 5 domains of the patient safety structural measure are on this slide, focusing again on whether or not there's leadership commitment, how safety is evident in strategic planning and organizational policies, culture of safety and learning health systems, accountability and transparency, and whether or not there's activities that reflect meaningful engagement of patients and families in this work. This is just an example of one of the domains under strategic planning and organizational policy. Again, it's an eye chart, but there are things here that are very, very inextricably linked to safe systems and medication safety that are on this list. And you can see the same under culture and safety and learning health systems. And the same is true for age-friendly care, whereas, you know, the 4 M's, medications, what matters to patients, mobility and mentation are all evident in that process. So with that, I just wanted to close down and also note that building competencies in the workforce is an important part of what we do. The Certified Professional in Patient Safety credential is now held by over 7,000 people across 32 countries, many of whom are from the anesthesia community. And we have just about certified 1,000 third-year medical students at the Texas College of Osteopathic Medicine. Dr. Jonathan Cohen is actually one of our faculty for their review course, and he's with us today. And we'll be introducing human factors in healthcare and age-friendly certification exams in the next year. Sorry, Nat.
You're actually fine for time. Don't rush.
Oh, now you tell me.
But I have a question.
Okay, and I also wanted to just note, you know, with the emerging, you know, interest and fascination and the intense involvement with artificial intelligence or augmented intelligence, we have a new report from the Lucian Leap Institute that resulted from an expert panel that we did back in January that has a range of recommendations related to patient safety for groups like developers, healthcare leaders, clinicians, patients and family advocates, and patient safety and quality colleagues, and an upcoming second part webinar. We did one 2 weeks ago that's on our website on how AI may impact the work of patient safety professionals. And this is all presented by our co-chairs, Dr. Bob Wachter and Dr. Kabe Shoshanya, who have made an indelible mark, I think, on where we're headed with the use of technology in healthcare. And with that, Nat, I will concede and turn things over to you.
Well, actually, if you'd stay. Thank you so much. If you stay at the podium, I have one question. We're in good shape for time. I've known you over maybe 15 years in various different roles, including here at the Seaport in the National Patient Safety Foundation, working with Tejal Gandhi. And I wonder if you could do two things. One is explain the overlapping Venn diagrams of NPSF, the Lucian Leap Institute, the IHI, and how we as an audience of safety people would know which organization to connect to in certain domains, and also maybe just describe your own career journey through those organizations. And
you wanted
really,
to end on time. Okay, so that's a great question about, what are the entities that we're talking about? As many of you know, the National Patient Safety Foundation was founded in 1997. So after the IHA's founding in, I think it was 1991. Ultimately, and Jeff Cooper's a fabulous historian on this too, because he was central to the core work in the board of National Patient Safety Foundation, because we were across the river from one another in Cambridge and Boston ultimately, and because we were kind of running into each other at so many conferences and in so many committees, and we had a lot of similar pieces of work. There was a decision to merge the organizations in 2017. I came from NPSF. We kept both brands, the brands of NPSF and IHI, as many organizations like the ones you're working in tend to do when there are mergers. And ultimately now we all fall under IHI. With incredible legacy and I think honor to the work of the National Patient Safety Foundation, which includes the Lucian Leap Institute that was founded in 2007, co-chaired by Dr. Lucian Leap. The Lucian Leap Institute continues its work. It's a program of the Institute for Healthcare Improvement. And we are heavily focused, I actually serve as senior sponsor for the Institute. We're heavily focused on setting the compass for the future of safety and taking on new challenges and opportunities such as our artificial intelligence. And now we're going to switch. No?
I'm going to keep pressing it. We're in the city of Boston, and I think it might be useful to at least mention Betsy Lehman's name, the year it happened, and how it impacted this city's energy around patient safety, and why it's so exciting to be here.
Okay, we didn't prepare for all of this, but I'm happy to share what I know. I think it was 1992. Betsy Lehman was a very, very popular columnist for the Boston Globe, who was being treated at the Dana-Farber Cancer Center and experienced, you probably know this better than I do, a substantial overdose that resulted in Betsy Lehman's death. There was this cataclysmic impact, I think, in the Boston area, and many of you are from the area, may have some interesting reflections as well, that really kind of put patient safety on the map. It kind of moved from, we had Tueris Human in 1999, but this was kind of the starting point, I think, for public recognition in this broad community here. And as a result of the strong visibility that Betsy Lehman had, there was an investment by the state of Massachusetts in the Betsy Lehman Center, which continues its wonderful state-funded work. We partner with them regularly and sit on a number of committees together to be able to address safety in Massachusetts. 2 years ago, the Betsy Lehman Center released a roadmap for patient safety in the state of Massachusetts, very, very similar. And I think one of the nice things about the work is the alignment between the roadmap for patient safety in Massachusetts with what I shared with you about the National Action Plan that was issued a couple of years prior, very, very similar to the work that's going on with the patient safety structural measures and the PCAST report, which was issued last September, that is on the president's desk right now. And we're not sure where that's going. We know this is not a good time to be sitting on the president's desk, but I have hope because they've recently assigned a good colleague from the Agency for Healthcare and Research to the Office of Science and Technology of the President. And we may be hearing in the next few weeks if there'll be a related hearing and event in DC that coincides with World Patient Safety Day on September 17th. Now, I think that's enough.
Okay. Thank you, and God bless you for all the work that you've done. It's my pleasure to introduce Rita for a terrific presentation, and maybe we'll ask who attended the
Absolutely,
consensus round.
absolutely. So hi, everyone. My name is Rita Ju. I'm president of the Institute for Safe Medication Practices, and most people call us as ISMP. And before I start, I would just say that, oh, and by the way, I'm a pharmacist by training, but I've been working throughout my clinical years with lots of anesthesiologists and had definitely enjoyed working in the perioperative space. But before I start, I just thought, for those of you who might not be as familiar with the Institute for Safe Medication Practices, I will give you a two-liner of what we do. We are the only 501c3 nonprofit organization that is completely devoting to preventing medication errors. And we do our work by really running our medication error reporting program. We have practitioners, like a lot of you sitting here, voluntarily reporting medication errors to us. So we run this national medication error reporting program where we will collect this information and we analyze them. And unlike a lot of medication error reporting programs, we actually go out and reach out to our reporters to try to get some more information to understand the root causes of the problem. And with that, and information we got could be actual errors that happen, but a lot of times it's also near misses that happens that was reported to us. And we disseminate these information with risk reduction tools and error prevention strategies through our newsletter. We also put together guidelines and best practices to prevent medication errors. And the ones that I'm going to be talking to you about today is the ISMP guidelines for safe medication use in the perioperative and procedural settings. So by way of background, ISMP received a grant funding from the US Food and Drug Administration, and the study period was between 2019 and 2022. And the goal was to identify and quantify the current state of perioperative medication safety practices in US hospitals and ambulatory surgical centers. We first assembled a multidisciplinary advisory panel consisting of anesthesiologists like yourself and certified nurse anesthetists and perioperative nurses and pharmacists, as well as medication safety experts to develop the ISMP medication safety self-assessment for perioperative setting. And the assessment was released nationally in 2021 and closed in early 2022. And in 326 hospitals and 60 ASCs provided their data during this period. And from this information, we identify safety gaps, and this also informed the discussion of a national summit that Nat was talking about. So in November of 2021, ISMP hosted the Consensus Building National Summit titled The Future of Perioperative Medication Safety, Charting Our Path Forward. And I would ask in the audience, if you can raise your hand, if you have participated in this conference. I know that there's quite a few of you. Thank you very much.
Cool.
Awesome. So as you can see, we have invited clinical experts, anesthesiologists, CRNAs, OR nurses, pharmacists, and also representations from professional organizations. I have to give a shout out to this organization, APSF actually not only participated in our summit, but also sponsored the summit. Other organizations, professional organizations such as the Association of Perioperative Registered Nurses and a lot others have participated. Government agencies such as the U.S. Food and Drug Administration has participated, and accreditation agencies like the Joint Commission, as well as quality and safety organizations such as the IHI and the ASC Quality Collaboration. And most importantly, we've also included the, industry leaders, because we know that we can't solve our problems without our industry collaboration. So the focus of the summit is to explore the current barriers to adoption of known medication safety practices and identify future opportunities to limit the risk and advance safety in this setting. And from that, we drafted the ISMP guidelines for safe medication use in the perioperative and procedural settings. And we have recommendations in 10 key elements. And what I'm going to discuss with you today is a few of these elements that is highlighted in blue. But before we start, I just thought I would share a case with you. And this is actually a recent case that was reported to us about 2 months ago. Here we have a 55-year-old with a history of hypertrophic cardiomyopathy with permanent atrial fibrillation, status post Watchman device placement, was presented for a 1-month follow-up for a transesophageal echocardiogram. The procedure was performed under general anesthesia with a natural airway. A CRNA removed what they thought was a vial of lidocaine 1%, which is 15 milligrams per 5 ml injection from an open matrix draw of an anesthesia cart, which is a common setting in the cath lab, and went ahead and prepared this thought to be 15 milligram dose of lidocaine in a syringe and administered to the patient. Shortly after, the patient became apneic, so the procedure was paused and the patient was bagged. The team then discussed potential causes for the unexpected apnea and found that instead of lidocaine, the patient actually inadvertently received rocuronium 15 milligrams per 5 ml. At that time, Sugammadex was administered for reversal of this neuromuscular blockade, and the apnea subsided. And the patient went on to complete the procedure and recovered from the procedure without any incidents. Now you can see in the bottom of my slide, the lidocaine and rocuronium injections were both supplied in a 50 milligrams per ml vials with a blue cap. And unfortunately, they were stored right next to each other in the anesthesia cart. So the CRNA relied on visual cues, the cap color, and the storage location to identify what they thought was lidocaine, but unknowingly administered rocuronium to the patient. I would pause and ask you to think about how many times did you reach out to the storage location using the visual cue of maybe a cap color to pull a medication and forgot to validate that that's the actual medication. That is actually the medication that you're looking for. So hence, because wrong medication administered to patients because of syringe swap or wrong clinical decisions in the selection of medication is the #1 cause of medication error in the perioperative area, we recommend that drug labeling, under the drug labeling and packaging and nomenclature section, that readable labels that clearly identify the drugs on all drug containers in the perioperative setting, and the drugs remain labeled up to the point of actual drug administration. And some of the details of these recommendations actually included a very audacious goal of eliminating handwritten labels and including machine readable code on labels by 2025. Now, we purposely call it machine readable code because we know that technology is evolving. And besides barcode scanning, there's other technology like RFID that could be used in the future. And hence, we really wanted to make sure that we eliminate these handwritten labels and have machine readable coding on these labels. While I know that 2025 is a few months, it's coming up in a few months, I know that not everybody can be implementing this goal. I'm hoping that with this audience, you can help us accelerate this implementation of this goal, and maybe by the end of 2025, we have a sizable number of organizations that would have implemented this goal. In addition, we have details of what is listed on the slide that should be included in the label, including the full name of the drug, the concentration and dose, not just the name, but the concentration and the dose, and other details. Finally, there should be verbal and visual confirmation of all medications delivered to the sterile field with the above information as well. Now, having these labels, the recommendations for these labels not only can prevent wrong drug errors, but also set us up for the next recommendation under the quality process and risk management, which is implementing redundancy that support independent double check or automated verification process to detect and correct serious errors. You all know that in the perioperative and procedural areas is the only area in the acute care setting where a provider is responsible for selecting, preparing, and administering medications and solutions without any other additional double checking. So that's why we recommend these redundancy, and we recommend a technology vendor partner with anesthesia providers to incorporate workflow in the development of integrated machine readable coding and documentation systems. We know that we're not totally there yet, and hence we definitely needed our technology vendors to collaborate with us to make this happen. And using machine readable coding in the pre, intra, and post-operative procedural settings to verify patients, medications, and solutions prior to administration, and also implementing and integrating this machine readable coding to support real-time EHR documentation of medications and fluids. I know a lot of you is probably sitting there and going like, wow, this is a lofty goal, but if you are at all thinking that this is the right process, which I know you all know that this is the right way to do, because we know that barcode scanning of patient and medications prior to administration have eliminated a lot of medication errors. And hence, this is the setting where you need to be implementing these technology. And if you really seriously considering doing this, please go and talk to Dr. Nanji, who's sitting right here, because she definitely has been the pioneer in this work. Okay. And to introduce the next recommendation, I just wanted to present you with yet another case. And this is a resident who was starting a Mironone infusion in the OR, could not find the Mironone in the anesthesia mode on the pump, and proceeded to enter a drug concentration and infusion rate manually. The Mironone concentration was incorrectly entered as 200 micrograms in 100 ml instead of 20 in 100 because of misreading of the Mironone bag. And you can take a look at the bag on the right-hand side and see how it's easily misread. However, because just note that this misreading and misprogramming resulted in 100 times lower the concentration, which when the resident put in the intended dose rate of 0.25 micrograms per kilo per minute, the dose was 100 times higher than intended. Since the dose area reduction systems was not engaged, there was no alert to the resident for this erroneous low concentration. And by the way, just a side note, this vendor for this pump also have transitioned the hard stops to a soft stop in the anesthesia mode. And so someone can easily bypass that alert anyway, even when there's a catastrophic limit, just like this one that was entered. So the 100 ml bag of Mirinone completely infused in a very short time, and that's when the resident realized that an error has been made. And because of that, the patient required observation and supportive care in an ICU, but did not suffer any serious adverse events. So hence, the medication under the medication delivery device acquisition, use, and monitoring, we recommend that smart infusion pump technology with dose error reduction systems be implemented. And I know a lot of you guys would say, yes, we already have that, but get this, we do want to make sure that you use that 95% of the time or greater. And the list of medications that we've included that should be included in this DRS system is continuous medication infusions, intermittent and secondary infusions, regional anesthesia infusions, patient control anesthesia, and IV hydration solutions. I know we can debate a lot about these IV hydration solutions, and we had some quite fun deliberation during our summit, but we ended up putting this recommendation in our guidelines because we have seen too many errors of free-flowing fluids that was occurring that smart infusion pumps can prevent. And hence, we're leaving that in our guidelines. And finally, we want to make sure that there's separate libraries for anesthesia that includes both the upper and lower heart limits for specific patient populations, because we are all human and fingering issue is common, and there has to be some limits that is catastrophic that will require a heart stop. And we also want to make sure that the limits include loading doses and boluses, and that there is audible clinical alarms to alert you about these limits being reached. And finally, implementing bidirectional interoperability with EHR. And that concludes my presentation. Thank you.
We're in good shape for time. I want people to prepare good questions about some of these incredibly ambitious goals that Rita has set forth, and also compliment her for these extraordinary case studies that she brought forward. And I also would like in the discussion for Rita to talk a little bit about reporting to PSOs. What is a PSO? Are they related to the state, et cetera? Who has access to mine their data, and a little bit about that. But please go ahead, Adrian. Thank you so much for being here.
Thank you very much for including me in the program as an invitee and giving me the somewhat dubious honor of speaking for about 80% of the world's population about the challenges that face them, which are totally different to the challenges we've been discussing and we're going to discuss. My email address is at the bottom of that slide. Happy to hear from anyone with input or gentle criticisms. Disclosures, none relevant to this presentation. Just a little history of the World Federation of Societies of Anesthesiologists. Founded in 1955 at the First World Congress of Anesthesiologists. As you can see, the United States did not join. The ASA was concerned, it being the McCarthy period, that the WFSA was a front for communist entities. But by 10 years later, it was apparent we are not a communist entity. And who knows, by next year, this time, Russia may be our biggest ally. We're a federation of national societies of anesthesiologists representing 150 countries. People often ask me, how do I become a member? If your national society is a member, the ASA is a member, you are members, and you are welcome to participate in anything WFSA does. Our programs are shown there, which does include advocacy. And a lot of my time, particularly at WHO, is spent in advocacy, both for the profession and for patient safety. And patient safety is an integral part of all of those programs in their different facets. WFSA is the official voice of anesthesia at the World Health Organization. Put it in WHO jargon, we're a non-state actor in official relations. And what that means is that we do have the right to make representation to the WHO Executive Board at their January meeting, and to make representations to the General Assembly of the World Health Organization when they meet each May. They've whittled the time allowed down from 3 minutes down to about 1 minute, so one has to speak fast and be very focused. And I've had the pleasure, the privilege over about the last decade to be one of the active individuals turning up in Geneva and making a nuisance of myself at WHO on getting anesthesia and perioperative care onto the agenda and the discussion. Many people are not aware of the fact that the WHO is in fact a United Nations subsidiary, and therefore is bound by all of the constraints and problems and fuzziness of the United Nations. WHO cannot mandate anything. All it can do is highly recommend, or suggest. It's their words. Highly recommend would be the equivalent of mandatory, but they cannot mandate. United Nations would love to mandate peace in Ukraine or the Middle East. They can only recommend it, and they have no ability to enforce. So in terms of patient safety, they can make lots of recommendations. They can create tools. They cannot enforce in any way. This diagram's from an article, a review of ours on the mess that is global opioid regulations, which may give you some insight into the two opioid crises we face in the world. We focus on one. The other 80% of the world focuses on the other. And there is a dynamic tension between the WHO on one side and the Commission on Narcotic Drugs. WHO interested in the healthcare perspective, the CND and its subsidiaries largely populated by law enforcement people. So we're about how do we use poppies for the benefit of our patients, and they're all about how do we burn all the poppy fields and bomb the hell out of the Taliban, who are largely funded by making and selling poppy products. If we look at preventable medication errors in low resource settings, we see a very, very different picture. The report from these 26 hospitals, about an 8% error rate. 83% of them we would view as preventable. But look at the failure to rescue, a death rate from medication errors of 30%. That is astonishing. And the authors of this article believe that's an underestimate, which I believe is true. The vast majority of countries cannot count births and deaths. Hard to know who's around and what the actual mortality rate is. There are startling reports of a discordance between a ward log of deaths and the mortuary rate. How do 30% of the patients disappear without going through a mortuary? Somewhere out of a back door. And what are the factors? The factors should be familiar to all of us. It's the usual culprits: lack of training, lack of supervision, no protocols, no policies, and inadequate communication. No different in that regard. The WHO now has a panoply of medication safety recommendations and resources. They are wonderful resources. The WHO makes all of their products free. You don't have to register. You can just download, and they are incredibly useful and well made. but anesthesia and perioperative care is not there. And over the course of about 3 or 4 years, they were persuaded that maybe there should be something. And I thank Karen Nanji for taking the lead in putting together a multinational document that is, Karen, I assure you, slowly moving through the endless bureaucracy of the WHO. Karen also won a WFSA Innovation Award to do a global Delphi so that we could create medication recommendations structured by country or region finance. Rita has just spoken about barcoding. There are many countries where a piece of tape and a pen to label a syringe are not available, and they view their biggest challenge as, how do I get a syringe that I didn't use on the last patient? So different priorities, similar issues, very different challenges, and we hope this kind of structure, moving things forward in a progressive fashion, will be helpful. Many countries have essential medicine lists. Interestingly, the 2 English-speaking North American countries, much of Europe, Western Europe, have chosen not to have essential medicine lists. I'm sure there's a very good reason that we could hear from the FDA or ISMP or others on why we don't believe in essential medicine lists as an important driver. The WHO does have a model list, as they call it, comes out every 2 years, and it does include a couple of pages of anesthesia medications. I'm currently in the process of leading a global review on these medications to report back to WHO so they can consider if they want to make any changes. Making changes essentially involves the equivalent of a Cochrane review. It's a pretty high standard of expectation to justify change. At the top of the screen, you'll see the #1 drug is halothane. And I hear a couple of sniggers from behind me. Yes, some of us have used halothane in our careers, but probably nobody in this room is using it. Halothane remains a very important drug in many parts of the world. This is a crude survey that we just did. This is out of a letter to the editor of mine that's currently in press. These are some of the countries where halothane is still used. In general, not at the major teaching hospitals, but in the rural communities. And one of the startling problems we've just run into is one of the major manufacturers has decided it simply ain't worth the money, and without informing anybody, just ceased production effective last December. I assume they informed whoever their distributors may be, who see no reason to inform anybody else. So I think what we need to put in place, at least in relation to industry, is at least a moral obligation to inform end users. And in our case, the best way to do that is through national societies. If a company is going to stop producing whatever it is, piece of technology or some medication, if they're going to send a note to their distributor, CC it to the National Society of Anesthesia or just simply to WFSAHQ.org, and we'll do it for you. We also need some simple metrics. We've worked on modifying some metrics that were laid out by the Lancet Commission on Global Surgery in 2015. And although most people see these kind of national reporting metrics as pretty dry, in the case of the Lancet Commission metrics, they are actually ultimately about patient safety. And the thinking in putting these things together is what is accessible by every country, not just our country, but what can every country do? And the crudest indicator of patient safety is counting dead bodies. It's horrible to think about it that way. We're here to talk about the nuances and finesse, But the reality is, for much of the world, counting dead bodies is as far as they go. What are the components of important? Safe access to get to healthcare, an adequate, well-trained workforce, an adequate volume of experience in order to do things correctly. And patients also need financial safety. Money is a huge disincentive for patients to seek healthcare, but for healthcare institutions to implement safe practices. If we could do all of those, then we would have happy patients around the world. To foster this, at 2 face-to-face meetings that were funded by Laerdal, we created a progressive disaggregation, really thinking about what should every country be able to report in 2 years, in 5 years, and sometime in the future. We do not include specifically medication safety metrics yet, or some omnibus simple measure other than death rate for patient safety. And I would love to see some kind of metric developed that we can put into this kind of package. We are currently in a discussion with WHO in them adopting this as a recommendation for national reporting on patient safety. So in conclusion, medication errors are endemic globally. Frequency and mortality is orders of magnitude worse than it is in high-income countries. WHO has a huge portfolio of resources on medication without harm. We're hoping it will soon include a very nice, straightforward document on the perioperative period. WHO cannot mandate or enforce or punish. We have to do that ourselves. An income-linked set of medication safety recommendations would be helpful, thinking along the lines of they need to be accessible metrics, they need to be comparable, everybody understands the definition, and they need to be actionable or utilizable. And I would just remind you that September the 7th is World Patient Safety Day. The United States government, in fact, all 194 governments voted in favor of this about 5-6 years ago. This year's theme is diagnostic safety, but I would encourage all of you at your own institutions and us as a collective to make a noise on September the 17th about patient safety. Thank you very much.
Well, please join me in a round of applause for all of our speakers and their fearless advocacy for raising the bar in everything that they do. We are scheduled to have a break from 9:10 to 9:30 and return here for the second session. That gives us a couple of minutes for any questions from the audience, particularly anybody wanting to push back on any of the recommendations that Rita outlined that came from the perioperative medication safety summit that so many of us in this room attended. Okay. That's an alarm for something. So does anybody have, oh, I see, good. David Cullen.
Yes, I'm a retired anesthesiologist and worked extensively for 10 years with Lucien Leaf on the adverse drug event study. I'd like to just simply point out that his book, which I recommend if you're not familiar with it or you haven't seen it, is a compilation of the entire medication safety program. And that book came out a year or two ago. It was reviewed by Fred Orkin in anesthesiology in 2022. And I highly recommend it.
And actually, that reminds me, Lucien and Greg Meyer published 2 articles on the issue of respect and physician behavior relative to the entire workforce. And I both heard Lucian give a talk about that, but these articles are extraordinary, representing a committee of the Harvard Medical School that basically said, and has resulted in changes in who is employed here. And so the power of Lucian's work cannot be overestimated.
You had asked about Betsy Lehman, and when our first major publication was coming out in JAMA 3 weeks before Betsy Lehman died, and the publicity surrounding that article on medication, adverse medication errors and their results got enormous publicity, and it just shows the power of the press when there is a personal anecdote that matters to people.
And also, while we're shouting out about all of that, I'm trying to remember the name of the person who came to lead the Dana-Farber Cancer Center and who really helped rebuild Jim Conway. Yes, and I just wanted to shout out Jim's name. Extraordinary leadership at a time of a massive crisis around the Betsy Lehman story. So a lot of things have happened in the city. Matt Wenger has a question, and then the next questions are at this side and over there.
I have a question for our FDA colleague. For medical devices, prior to approval, clearance, every device manufacturer has to do a use-related risk analysis. And I wonder for medications, whether something similar might be in place, and if not, could it be, especially for packaging and labeling, but even for general use and the potential for harm ought to be prospectively analyzed, and the burden should be on the manufacturer, not on the public. Thoughts?
Sure. Do you want to come up to the podium since we have 200 people streaming, or there's a hand mic that will be brought to? Well, why don't you start here while we get the whichever. Good enough. Thank you so much.
Thank you for the question. It's actually interesting. Yes, we do. We do encourage the manufacturers prior to even submitting in their pre-IND phase to start thinking in terms of the medication safety aspects, proactive risk assessment. We do have several guidances published out there that specifically talks about the safety considerations related to product design, packaging, container labels, carton labeling, as well as user related considerations. So we do, and we also review specifically human factors studies results, specifically for the products that have a device components. We do ask certain data if we do anticipate in the pre-market space if the product potentially we might have a concerns. Hopefully that answers.
Thank you. I want to go on to the next two questions.
Thank you. Rick Dutton, Chief Quality Officer, U.S. Anesthesia Partners, and full-time anesthesiologist in the Washington, D.C. area. At the risk of broadening the conversation, one of the most common medication errors I see in my hospital every day is failure to deliver an ordered medication in a timely fashion. And I wonder if there's any effort to look at this. If I look at a hospital chart, a patient who's been an inpatient for 3 or 4 days in my building, 100% have missed a dose of an antibiotic, their Lovenox, their round-the-clock Tylenol or Motrin. And I wonder how much these things contribute to adverse outcomes in our patients down the road. We're going to talk about opioid use disorder, getting a PRN Percocet because you missed your round-the-clock Tylenol because you were in the CT scanner, I think is probably a very common problem. And I wonder if there's any thinking going on about that.
Thank you very much. Let's put that in a great parking lot space for the next day and a half. And I want to go to this question.
Yes, I'm Amy Vincent. I'm a pediatric anesthesiologist at
You gotta
Boston.
speak up a little louder in the microphone.
Can you hear me?
No.
Amy Vincent. I'm a pediatric anesthesiologist at Boston Children's. I have an infrastructure question related to the point of care labeling machines, codonics, what have you, that are out there. They do allow a wonderful augmented intelligence second look when you use that barcode scanner. the barrier to using them is purchasing them. Are there any medical malpractice, discounts or government grants available or similar grants available to investing in this infrastructure that can help?
Well, actually, I think since this is a capitalist country, competition is what drives pricing down. There are actually competitors of the major brand right now. So I think that's probably the only way to kind of get the cost down to try to help implement some of these very important technology. So I would encourage you and your organizations to go out and look at their competitors.
Excellent. Well, with that, I want to initiate the break, but I get. Oh, sorry. Here, let's take the handheld mic. Oh, I'm gonna go. Here, let me bring this. Here. I'm giving you the handheld mic.
Thank you.
Great, thanks so much.
Thank you. So we have a few questions from folks online, and probably one more general is just to how to avoid dosage errors in pediatric anesthesia. That's probably a whole conference onto its own question there. But if anyone would like to answer that, they may. I'm going to give you all three, and then we can go from there. The other is more a general question around medication printing that offers size options. I imagine that might be from a more senior anesthesia provider. I don't know.
Can you re-ask that second question?
Yeah, sure. Medication printing that offers you a size option in what you're printing. So whether it's a size of syringe or it's a font size or whatever. I'm just bringing up what, I don't have more detail since the person's online.
Great. Well,
Yeah.
let's just defer it then.
But the last one that was brought up, is it a good idea to recommend drugs are stored in a pharmacologic class order and local anesthetics are stored completely separately? Is there more organization in how we manage our medications that are in the operating room?
Does anybody want to take that?
So the question is is the question, can I get a clarification that the question is whether should they be stored by classes or not? Well, this is interesting. I'll tell you personally, I was working with, we were opening in my previous life, we were opening up an OR and trying to put together an anesthesia tray with all the medications, and my technician supervisor put together a nice tray based on ISMP's recommendation. And the anesthesiologist took a look at it and say, this is not how we do things. We got to redo this. And that's because we were segregating some of the localite items when things are supposed to be gathered together by drug classes. So ISMP does not have specific recommendations of whether you should be gathering all your same drug classes into one location. I know that this is a practice by anesthesiologists because you think in terms of classes. I think there is ways to try to segregate drugs that are look-alike or sound alike by the different, and put them separately in different areas so people won't be picking them out. A lot of the error, if you think about a lot of the errors that happened, a lot of times is because these drugs are used together in the same procedure. Tranexamic acid is a great example of why people are using intrathecally, right? So if you think in terms of that and think of how you can separate these drugs based on the likelihood that someone is going to be picking the wrong drug and have a catastrophic effect, I think that's how you should plan your storage in that way, so you can separate them as much as possible or differentiate them if you can use like a bag instead of a syringe or a vial.
Well, thank you all so much. I think this is a good moment. The breaks are important because they're a chance to network and to come up and address the speakers. Are there refreshments outside on the tables,
Yes,
so
so we're
you can
gonna,
go through the doors
Yes.
and get some cool
yes,
stuff
so we're
and come
gonna,
back in.
thank you. So I want to thank our moderator and our esteemed panelists for this session. We're going to take a 15-minute break and gather again at 9:30. For those of you that need Wi-Fi access, it's MGB guest. And I will see you at 9:30. Thank you.